Good afternoon, India, and all the doctors who are seeing us live on this emojious TOG webinar. This is our Mumbai studio. Just a quick insight to all the outward appearances. Louis Brown looked exactly the same as thousands of other babies when her blinking, slightly quizzical gaze met newspaper readers on the morning of July 25th, 1978. But as the first child born using the technique of in vitro fertilization, she was utterly unique in the history of humankind, wasn't she? Today, declining fertility rates are often blamed on wider changes in the Western women's lives in the early 21st century. I am sure COVID has provided enough reason for baby boom. And on a serious note, today we have amongst the country's top talent in the field of infertility. Let me take this opportunity to introduce them to you today. The Mumbai Obstetric and Gynecological Society, which was founded in 1934, presents the first live webinar of recent updates in infertility, supported by Sanofi under the leadership of our dynamic president, Dr. Reshma Pai. I welcome Dr. Reshma Pai. Can I have her slide, please? Dr. Reshma Pai is FRCOG, DNB, FCPS, FICOG, and DGO. She was the president of FOXI, ISAR, and IAGE, and presently she is assistant treasurer of International Federation of Fertility Societies. We know very well that she is a consultant in Lilavati, Jaslok, and Hinduja Healthcare Hospitals, and she has also been honored as a fellowship with Endem of the Royal College of Obstetricians and Gynecologists, London. Welcome, Dr. Reshma Pai. Please join us. Can we have our president, Dr. Reshma Pai, online?
Hello, good afternoon, everyone. Thank you, Niranjan, for the kind words. And for all of you watching and who have logged in, I'd like to say a big thank you for being with me all these years and for electing me as president of this very prestigious organization, the Mumbai Obstetric and Gynecological Society. I'd like to say that today, all of us have reached a situation completely unprecedented. Nobody would have ever believed that we would be in the situation that we are in today. All of us are fighting to survive personally and professionally. All of us are frontline workers, and the intense physical and mental stress all of us are going through at the present moment is really unprecedented. But survive we have to, and survive we will, and we'll emerge stronger and better. And MOGS is there for you through this year in whichever way we can. Of course, academically, we are going to be very active. We'll be bringing you very relevant, updated content in the form of CMEs, webinars, e-newsletters. In fact, I think the first e-newsletter has already reached you today, the MOGS Media on Preterm Birth. It's a wonderful newsletter put together by Dr. Pratik Tambe, so please do look at it. And of course, we'll be bringing you some interesting little tidbits in the form of pearls of wisdom, tiny bursts of knowledge for you to watch while on the go. In June, so soon, 21st of June, in fact, we will bring to you a focus conference on the focus on first trimester, with many international and national experts talking to us on this very, very important aspects. We have some other exciting conferences for you later in the year. There's a ME conference, myoma and endometriosis only, something wonderful, the Youngistan, brought to you by youngsters. We have the FEM conference, all of you are familiar with, on the subject of infertility, and a lot more. So look forward to interacting with you on all those platforms as well. However, we want also to bring a measure of relief amongst all this academics. And so this year, for the first time, Morgs will be bringing to you Morgs Has Talent, because I believe all of you have huge amount of talent, and that should be brought out and showcased to everyone. We also have a very, very interesting and a very difficult competition this year, the Morgs Personality of the Year contest. And all of this is going to be very, very transparent. You are going to be receiving information about it soon. And we will be having all these exciting things through the year. However, the main focus this year has to be on helping our Morgs members in every possible way that we can, whether it's by providing PPEs, masks, whether it's by helping you all set up some kind of a group practice which is necessary today, or even by providing consent forms with the help of all our medical legal experts. And we've already started working on all this, because consents, legal implications, all of this is changing in today's changing world. So really, I'm looking forward to today's CME, very wonderfully put together by Niranjan, the moderator, and our speakers really are probably the best in the country. Rupin Shah, there is really no one to even come close to him in the field of andrology. Jaideep Tank, many, many years of experience, and Rishikesh, of course, one of the pioneers of IVF in this country. So it's going to be a very, very interesting and informative webinar. And so, friends, let me end by saying, stay healthy, keep your morale up, and remember, morning will come. It has no choice. And so the dark will soon again go away, and there will be light soon. In the meantime, stay safe, take care. Niranjan, back to you to start the meeting.
Thank you, Dr. Reshma Pai. You took us through the whole insight of your year and the journey which we are going to travel through the first trimester and the other conferences which have been already said very nicely. And I would like to tell you, on this Saturday afternoon, we have got 950 viewers logged in to hear the big personalities in infertility of our country. And I would like now to show the slides of our speakers, so that I can officially welcome this. This is the first MOGS webinar. We have our esteemed speaker, Dr. Jaideep Tank. We all very well know. He's the Secretary General of FOXI and the immediate past president of MOGS. He's also the Deputy Secretary General of AOFOG. And he has his own consulting in Ashwini Maternity Surgical Hospital, Ghatkopar. And he has given many lectures and oration. We will hear from him about diminished ovarian reserve. What next? Can I have the next slide, please? We have Dr. Rupin Shah. He is the world famous andrologist and a microsurgeon with a degree of MCH, MS Urology. We all know and we have heard his lectures, so he is going to keep us spellbound with his charisma. He is the founder president of South Asian Society for Sexual Medicine and has specialization in microsurgical reconstruction for azoospermia, sperm retrieval for ICSI. He has also multiple awards to his credit, more than 100 papers, 24 chapters, and he is a Dr. B.C. Roy awardee. Welcome, Dr. Rupin Shah. Thank you so much. Next slide, we have with us Dr. Rishikesh Pai, the heartthrob of Indian gynecologist. He is MD, MR, FRCOG and FCPS, FICOG, MSc. We all know that he is the medical director of Bloom IVF Group, and he is the past Secretary General of FOXI and has put many hats, donned many hats like the president of MOGS, IAG, ISAR. He is also an administrator of FOXI Manyata Initiative, awarded with more than 30 awards, the most important being Dr. Malhotra's prestigious Lifetime Achievement Award recently at the ISAR conference he got in Hyderabad. He has got more than 16 books and written more than 50 chapters and has got numerous orations and has been invited as faculty across the world. Welcome, Dr. Rishikesh Pai. Thank you so much, all of you being here. Now I call upon our first speaker, Dr. Jaideep Tank. to start his lecture, Diminished Ovarian Reserve. What's next? Dr. Jaideep, the mic is yours. Please go ahead. Thank you so much.
Thanks to Thank you very much, Niranjan, for that lovely introduction. And thank you very much, of course, to Dr. Reshma Pai, her secretary, Dr. Anayta, and the rest of the team for including me in what I believe is the first webinar of Reshma's year. I know that it's going to be a great year, Reshma. So we are all with you, and we hope that it does turn out to be so. And I must say that it's a particular honor for me to be speaking with Rishikesh, whom I've admired since so long, and of course, Rupin Bhai. I can say that literally I have known Dr. Rupin Shah since I was a child, when I used to trouble him to on our family holidays to listen to his Walkman, which I didn't have at that time. So a particular honor to be speaking with them. I do apologize in advance that I have another webinar after this, so I will have to leave directly after my talk. But let me begin my talk on diminished ovarian reserve with this slide, which shows you a Medline search. So you can see that I've done two Medline searches here. There's one on diminished ovarian reserve, and there's one on poor responders to ovarian stimulation. And I hope that this slide illustrates 2 points. The first point is that diminished ovarian reserve and poor ovarian response is not the same thing. And the second point is illustrated by this graph, which you will see next to the slides. I know that all of us do a lot of Medline searches, but I'm not sure how many of us have actually looked at this graph, which comes on the side whenever you do a Medline search. Now, this graph is actually a very important graph because it tells you about the number of articles that have been published in the literature on the topic that you are searching for year on year. So, for example, if you have a graph which starts tall and then keeps on going down, it's an indicator that the number of articles which are being published on the topic under search are reducing every year. And because they are reducing every year, either all the issues in that topic have been sorted out, or there is no interest in literature anymore on that topic. But if you have a graph like this, which you will see exists for both these searches, which starts small and then keeps going on and on increasing, it means that the topic that you are searching for is still extremely relevant. There is a lot of interest in literature on it, and therefore this topic is extremely current. Diminished ovarian reserve in infertility, I believe, is one of those topics in fertility which is almost something which is end of the line. And it's rather unfortunate that what is cutting edge with its quasi-experimental therapies is sometimes misconstrued as routine practice. And therefore, this quotation that education is learning a lot about how little you know. And I really can't think of any topic in infertility to which this is more applicable. So this is the outline of the talk. We'll first talk a little bit about defining and measuring reserve. We'll talk a little bit about reproductive aging, followed by diminished reserve in young women, one of the big quandaries of our time. How do we prevent diminished ovarian reserve, and what treatment options do we currently have for diminished ovarian reserve? So let's first look at defining and measuring ovarian reserve. And I think this is one of the parts of the talk which will highlight the problems with the literature on diminished ovarian reserve. If you look at this article from the Free University of Brussels of 2011, you'll see that a comprehensive review of the clinical trials on poor ovarian response showed that until 2011, over 40 different definitions had been used. Now, mind you, we sometimes use poor ovarian reserve, poor ovarian response and diminished ovarian reserve interchangeably, but that's really not correct. But you need, in this instance, to use poor ovarian response as a surrogate, if you will, because the amount of literature on diminished ovarian reserve, as I will show you later, is quite limited. So poor ovarian reserve has had more than 40 definitions over a period of time. But then in 2011, there was the publication of the Bologna criteria, where poor ovarian reserve was defined as the collection of 3 or fewer oocytes and so on and so forth. And I'd like you to pay attention to the last article over here, which says presence of an abnormal ORT in a woman over 40 years of age. And I believe that this is one of the fallacies really of the Bologna criteria, which I will illustrate later. So we had criteria which were more or less universally accepted for poor responders, the Bologna criteria. The question was, how well did doctors adapt to this criteria, or how well did people who publish articles take these criteria up? And it was astonishing for me to read this article from 2018, which said that from the 109 published clinical studies and 112 unpublished or ongoing trials, the Bologna criteria were used to define poor ovarian response only in 51% of the published and 44% of the unpublished article. It's obvious this means that the Bologna criteria, although came out as a kind of a consensus, have not really been taken up very well in the community of researchers. There is still a lot of hesitance to use the Bologna criteria as a uniform criteria for producing literature on poor ovarian reserve. Why is this so? Well, it's possible that this is so because there are indeed problems with the Bologna criteria. So, for example, the definition of poor ovarian reserve using the same threshold of 3 or 4 oocytes regardless of age. That means the Bologna criteria does not stratify response as per age. The criteria represents a heterogeneous group of patients with diverse prognosis. And of course, all these articles have pointed out that there is a complete ignorance of oocyte quality and other factors that can be associated with diminished ovarian reserve. Moreover, there is a fairly arbitrary selection of 40 years as the cutoff level for age. All this kind of a confusion has also led to a confusion in the literature for diminished ovarian reserve. So I like to call it the alphabet soup of DOR. So there's DOR, there's POR, there's POF, and there are so many other things. So as I've already said, there are really no studies that specifically deal with the issue of the appropriate treatment for women with DOR-associated infertility. So first, there is the issue of defining DOR, and then there is the issue of research which is present in patients in whom the defined DOR actually exists. If you look at consensus on the concept of DOR, the definition is still blurry. There were 121 articles, and unfortunately, a lot of the articles just say DOR without defining diminished ovarian reserve. So if you look at this, out of 121 articles, only 14 of those articles actually gave a definition for what their criteria was to say that a patient has diminished ovarian reserve. And even within these 14, there were confusions. One thing which has been suggested, and I think this seems to be, for me, the most reasonable kind of a definition of diminished ovarian reserve, is to use these two factors, women with any of the risk factors for poor ovarian reserve. So you're already using something which there is consensus on, or an abnormal ovarian test, ovarian reserve test, that is an antral follicle count of less than 5 to 7 follicles, or an AMH of less than 0.5 to 1.1. The American Society of Reproductive Medicine has come out with its own definition, but for me, this definition is not really very good because it doesn't actually tell you how to make a prognostic kind of an evaluation for a patient with diminished ovarian reserve. So let's now look at how to define or how to use the ovarian reserve test. Ideally, the ovarian reserve test should accurately measure the extent of the primordial follicle pool, which is the true ovarian reserve and reflects the oocyte's reproductive competence. Unfortunately, all the tests that we have right now actually provide an indirect measure of the cohort of recruitable antral follicles at the beginning of each menstrual cycle. We would not know, for example, how many oocytes are actually there in the ovary. There is no test which is available like that. All the tests that we have are indirect measures. But from the tests that we have, and this is again from the practice committee report of the ASRM, we need to look at the sensitivity and the specificity of each of these tests and balance sensitivity and specificity. And I would like to add reproducibility before we can decide what we will actually use. So it seems to me that of all the tests, AFC and AMH had the best sensitivity and specificity for predicting ovarian response, and there is a lot of data to suggest that this is probably the way to go. However, let's always remember that even the best ovarian reserve marker at the best cutoff values is associated with a false positive rate of 10 to 20%. Ovarian reserve tests, moreover, have modest clinical ability because of their limited predictive properties. In some instances, it's actually been recommended that you use the response during the first IVF cycle as your ovarian reserve test. So you use AMH and AFC to base your dose, etc. on, but you arrive at a definition or you arrive at a conclusion of diminished ovarian reserve when you look at the response which the patient gives in her first IVF cycle. There is always a question as to what cutoff values to use. So for example, for AMH, the best cutoff values reported are in the range of 0.5 onwards. And for AFC, the values may range from less than 5 to less than 7. What is true, however, is that it's always better to use extreme values. It's not a good idea, for example, to say that I'll use an AMH of 1.1 as my cutoff value for diminished reserve, because these have high specificity and low, but although it implies reduced sensitivity. So women with a previous poor response to maximal FSH stimulation and a subsequent abnormal result may be classified with high probability as women of reduced ovarian reserve. So let's look at AMH as a standalone kind of a marker. And always remember that AMH as a standalone marker also has limitations. It's not something which is written in stone. It's important to realize that there are variations within AMH, like, for example, use of OC pills, ovarian surgery, endometriosis, smoking, etc. And there are times when you could get a discordance in ovarian reserve tests. So, for example, you may be expecting that the patient has a low AFC and therefore should have a low AMH, but turns out to be a high AMH or vice versa. What do you do in such a situation? So for purpose of IVF stimulation dosing, this would mean choosing an intermediate dose of gonadotropins as compared to those with concordant AMH and AFC categories on either end. When would you get this discordance between AMH and AFC? You would normally get it in a certain subgroup of patients, and an AMH higher than expected for a given AFC could suggest an upregulated AMH secretion, for example, PCOS, while AMH lower than expected could be seen as an early symptom of diminished ovarian reserve and premature ovarian insufficiency. Should you do ovarian reserve testing for all patients? Although there are certain indications that have been laid out, it is a fact that AMH testing is now extremely common and is done quite frequently. And if, again, as I said, if one were to choose what testing you should do for ovarian reserve, you should probably rely on AMH and AFC with extreme cutoff values. We all know that reproductive aging is a fact, and that as age advances, the level of AMH, the level of AFC, and the ovarian response all reduce. And therefore, it is important to now look at and counsel patients about the ability to freeze their oocytes, because there is some data to show that if women were to be talked to about reproductive life planning and they were defined as those having low ovarian reserve, then they could possibly choose oocyte freezing. I do believe that oocyte freezing is no longer an experimental technology. I think the technology has now matured, and I do think that it is something which I must caution you cannot be offered as a panacea for fertility, but certainly can be offered with confidence for future fertility. The vexing question is diminished ovarian reserve in young women. And we all have these patients who are, let's say, 25, 30, and so on, and still turn out to have diminished ovarian reserve. We don't really know why we have them, but from practical experience, I can say that a lot of the patients that I have seen in these kind of category have patients who have pelvic infections, particularly tuberculosis. Of course, if we don't have all the answers for diminished ovarian reserve, it would stand to reason that preventing diminished ovarian reserve is important. And for this, I have two talking points. One is fertility sparing surgery, particularly during surgery on endometriomas, and oocyte cryopreservation. the most important thing I can say today is all endometriomas do not need treatment. I cannot tell you, and I'm sure any IVF specialist will say the same thing. I cannot tell you about the number of times we have seen women who have come to us with repeated surgery for ovarian endometriomas, and by virtue of this have extremely low ovarian reserves to the extent that they now need egg donation. So the operative question is, when you have an endometrioma, first of all of them don't need surgery. And when they do, you need to look at cystectomy versus fenestration and fulguration. The operative question really here is one of recurrence. There is no doubt that if you do a cystectomy, you will have a lower incidence of recurrence, vis-a-vis opening the cyst and simply fulgurating it. However, always remember that even in the best of hands, there is always some amount of ovarian damage with a cystectomy. So if you look at this study, ovarian parenchyma found in 40% of cases of endometrioma cystectomy. And this study very nicely shows you that when patients have an endometrioma stripping surgery or a cystectomy, there is a certain effect on the AMH levels, which is not very good. So although excision may seem to be the treatment of choice, you should defer it where ovarian reserve is a concern. So any patient who comes to you with fertility and has an endometrioma, please consider just opening the cyst, draining it, and fulgurating the endometriotic deposits rather than stripping the entire wall. The question then arises, what about IVF after coagulation? Does coagulation impair IVF? Again, there is good data to show that not only does coagulation not impair IVF outcomes, even the presence of an endometrioma while doing IVF will probably not make any difference in the outcome. Of course, as I said, the second issue was oocyte cryopreservation. And this is, as I already said, something which has come with us to stay. It is a mature technology now, but does not seem to have a very high uptake, particularly in patients who need it for medical reasons, for example, cancer patients. And we really need to do more to make sure that they can get the benefit of it. When you look at the treatment options, I will take around 4 minutes more. I think I should finish in time. The first and the most important thing to realize is that a diagnosis of diminished ovarian reserve does not always mean that the patient will have a poor ovarian response. And this is the most important thing because, for example, you should not offer an egg donation immediately to patients who have markers which are positive for diminished ovarian reserve. You will see here that if a patient receives a diagnosis of diminished ovarian reserve prior to a stimulated cycle, there's only a 30.8% chance that she would meet the Bologna criteria for poor response. So as I have already said a couple of times, don't use the indices or the markers of diminished ovarian reserve to tell the patient or discourage the patient from undergoing a ovarian stimulation. The ultimate proof of the patient's ovarian reserve is in fact the stimulation itself. Besides which, you may have a poor response, but if you get good quality oocytes, you may still end up getting good results. So an epiphany here, a diminished ovarian reserve frequently results in a poor response to ovarian stimulation. However, a poor responder is not always someone who has a diminished reserve. And that's important to realize. Occasionally, you may have patients with perfectly normal ovarian reserve testing and still land up with a poor ovarian response. Some other treatment options have been suggested. There's DHEA, which is used very commonly, but the literature on DHEA is conflicting. If you look at all this data, it says that DHEA is not necessarily very useful. But then if you look at other data, it seems to suggest that it could have some role in improving clinical pregnancy rate. A lot of medications are used. This is something called as a Chinese recipe, a BSTCR, although I'm sure that nowadays we would be hesitant to use anything recommended by the Chinese, particularly in medicine. But, there is something to sort of look forward to. The last part of the talk looks at ovarian stimulation for diminished ovarian reserve. We know that growth hormone has been used. However, it's not really been proven to be very effective. It pretty much doesn't matter whether you use an agonist or an antagonist cycle. Personally, I prefer to use antagonist cycle for poor responders, but the literature is equivalent on that, is equivocal on that. Natural cycle IVF for minimal stimulation, according to me, is not really very useful, both in terms of efficacy as well as in terms of cost effectiveness. So you will look, there are several studies like these. I'm just showing you one of them, where it was proposed that you add either clomiphene or letrozole and try and there is, again, this is a Cochrane database study which shows that really you don't really improve anything by adding clomiphene or letrozole for that matter. There was this one study which actually seemed to be a little promising, where they say you should do 2 ovarian stimulations. But I sort of, this is really one of those studies which makes me wonder how it got published, because look at the conclusion. Each woman had double the number of mature oocytes collected following a double ovarian stimulation. Well, obviously, because, she had 2 ovarian stimulations, so she's naturally going to get, twice the number. Sometimes I don't understand how these studies get published. There is some research to show that corifoliatropin alpha, there was an hypothesis whether that was useful. Again, it's not really turned out to be that useful. This is a promising approach where you use luteal GnRH antagonist pre-treatment when patients are suspected to have DOR. And that is something which could be useful, but not something which I'm confident to say is the standard of practice. And I like this sentence. That's why I put up this study. Gonadotropins cannot compensate for the absence of follicles in the ovary. Therefore, if you have any treatment which you're going to offer, you please take into account cost effectiveness. A lot has been said about PRP. There is a lot of buzz on social media and the media about it. Unfortunately, if you really do a literature search, it's quite disappointing. The number of patients or number of reports are only case reports. There are hardly any, there are no randomized controlled trials of PRP. And look at what I've highlighted in red. The mean number of oocyte before and after PRP injection was 0.64 and 2.1. So what are you really achieving by doing this? I think this may be promising in the future, but as of now, I don't really see it as being a standard of practice. Even someone who actually holds a provisional patent for process and treatment using ovarian PRP admits that. This is the last thing, and this is something which I got very excited about, because one of our patients who failed in 4 or 5 IVF centers here went to Brussels. They used this calcium ionophore treatment for the patient. The patient conceived and has a baby boy. And this is something which we are using on a daily basis. There is something to suggest that using calcium ionophore after ICSI may be helpful. We have some experience with it, but right now our experience says that it's not, turned out to be the panacea that we thought it is. So this is my last slide, and I'd like to end with these 2 pictures, which I always find very touching. The picture on the right, for example, is a baby born to a same-sex couple, a lesbian couple in the UK. And as they said, 4 years, 7 attempts, 3 miscarriages, and 1,616 shots. After both these babies were born, the parents had saved all the syringes and needles that they had, taken throughout their treatment, made a heart out of it, surrounded the baby, and then took a picture of the baby. And I think that speaks to me about the emotional investment which patients have in treatment. And it, of course, therefore behooves us to do treatment for these patients in the best way possible, in the most ethical way possible, and of course, in the most cost-effective way possible. Thank you very much.
Thank you, Jaideep. It was a wonderful presentation you did, and especially your slides were so good that you did ensure that we were taken back to asterisks and obliques, wherein the magical potion was brewed by Gitafix, if I'm right.
Yeah.
So I will be asking you, Jaideep, 2 questions which are being asked by our esteemed delegates, and I would like to say here that we have got more than 1,250 members who have logged in now, and it's really great. So Dr. Tank, your slides were really, really wonderful, and it was very concise. So we asked the first question, which is from Malegaon, Dr. Shashikant Wawar. Jaideep, why different lab have different AMH levels for the same blood sample?
Okay,
please.
That's a very good question, and the answer is very simple. Actually, it's because different labs use different kits for measuring AMH. And in fact, if you really see, if people who've been in practice for a long time and have been doing AMH for a long time have seen this trend of reducing AMH levels in patients. This is not because ovarian reserve, because of some environmental reasons, etc., has gone down. It's because the reference values have changed, because the kits for AMH have gotten better over a period of time, and they have been able to arrive at more better mean of medians for the reference values. So that's really the reason why different labs have different reference values. It's nothing to do with the population which they are serving, but everything to do with the kit that they are using.
Thank you. One more question. Dr. Pallavi Agarwal, DHEA is to be given in which cases of DOR?
Okay, there's no clear answer about that. In fact, there is no very good evidence to suggest that DHEA makes a material difference. The way we use DHEA, and I must say that I use it in a very, very limited fashion. I probably give maybe 2 or 3 prescriptions of DHEA in the entire year of practice. We really use it for patients who are unable or unwilling to undergo IVF or egg donation. And over there, you have to give some form of empirical treatment. Yes, I'm going to go ahead and call DHEA as of now on the basis of current evidence and empirical treatment, because we are not really sure that it works. And like all empirical treatment, it should not do any harm. So you should not give it for too long, and you should not give too much of it. So normally when we give this, as I said, we give it empirically, and we don't give it for more than 3 months.
Thank you, Dr. Jaideep. I know you have to go to another webinar, and it was a pleasure to have you with us. And we are going to see you. Yeah, we are going to see you often. Thank you so much, Dr. Jaideep.
Thank you. Thank you. So I'm sorry, Rupin, but I'm going to miss your talk, and Rishikesh also.
Well, thank you. Well, the beginning of history of modern andrology as a clinical science can be located in the mid-century of 1900. The term itself, andrology, was first proposed in 1951, and today we are happy to have with us the best andrologist of our country, and I can see the graph of users has gone up now to 1350, and we are all waiting for your lecture. The mic is yours. Please go ahead, sir. Thank you.
Thank you, Niranjan, for that very warm introduction. Congratulations, Rishma, for becoming the first president to be brought in electronically by virtual meetings. And this is, of course, just the first of your many, many, many meetings, which I'm sure will be very successful. So this is supposed to be an update, but the main audience is the general gynecologist. There are 1,300 of them. That's quite remarkable. I would have thought you would have a Saturday afternoon nap planned instead. But since we have decided to stay awake, I would like to discuss not something very new and exotic, but rather the day-to-day questions that the average gynecologist with a limited infertility practice still encounters, and try and give you answers to those. So these are basically the common questions that I'm frequently asked in workshops, and therefore the list of questions that which problem do you face and how do you take care of them. So the first step in the evaluation of an infertile couple, not just a man, of a couple, should be a semen analysis. And often the question I'm asked is that our patient has a problem with semen collection. The man says that, "Doc, you asked me to come back with a semen report, but I could not collect it. So what do you do?" Bear in mind that a fair number of our population are not accustomed to masturbation, and maybe 1 out of 10 men have difficulty in collecting a semen sample. So always when you ask for a sample, ask the patient, will he be able to collect a sample by masturbation in the clinic? And if he says no to any of those, then you have solutions. Allow him to collect it at home, bring it within half an hour, 1 hour, doesn't matter, as long as he keeps it at body temperature. If he can't collect by masturbation, let him use coitus interruptus. Special non-spermicidal condoms can also be used. And in rare cases, we have penile vibrators that give a strong stimulus to the undersurface of the glands, and that can result in an orgasm and collection of a semen sample. Now, once the semen sample is collected, there's a whole range of questions that come up related to the semen analysis. First question is, oh, my patient has low semen volume, what do I do? First thing, obviously, is rule out short abstinence. Sometimes he's ejaculated in his sleep the previous night, and therefore there was not enough time for abstinence before the semen collection. Spillage is common, and some men actually think collecting one squirt is enough. And sometimes they may have had difficulty in collecting. You ask him, were you able to collect? He says, no, doc, it was very tough, and I really had to struggle, and only a few drops came out, and that may not even be semen. So whenever I see a semen report with low volume, I will first rule out these three factors, and if there's any doubt, repeat the semen test. Now, if the patient says, no, it was a proper collection, proper abstinence, but the volume was low, then you have two groups of patients, those who have low volume, but some sperm are present in the semen, and those who have
Dr.
low volume,
Rupin?
yeah.
I'm sorry to interrupt you, but can we have the slides, please, which you have to share? If
You're
there are
not seeing the slides? Oh, I've been looking at the slides all this while. I wish you'd told me
So it's
earlier.
okay, it's okay, sir. Your voice is so lovely that everyone has understood. We don't need the slides, but if surely they are there, we would love to have them. Please press
They are very
the
much
arrow
there.
up. Yes,
Okay,
yes.
now are you
Thank
seeing
you.
them?
Absolutely. They
Okay.
look beautiful, wonderful. Thank you so much.
Okay, my
Please go ahead.
apologies to everyone. I thought the slides had been shared. I think that's what happens after too many Zoom meetings. One develops webinaritis and forgets the basics. So here
Yes,
we are.
please.
There are two kinds of problems with low semen volume. So you missed the previous slide. Let me show you the vibrator and the previous slides
Yes,
very
sir.
quickly. So this was the first problem, semen collection. And 10% of men would have such a problem. And these are the various solutions that you have. And this would be a vibrator that can be used to collect the semen sample. Now we'll move on to the next slide, which is the low volume ejaculate. And as I mentioned, rule out the other causes. And then you have two possible situations. If someone has low volume but sperm are present, then this is possibly a case of partial retrograde ejaculation. And you may see this in your young men who have juvenile diabetes because they have neuropathy that damages the bladder neck. So the semen volume progressively diminishes. At some point, the semen may actually disappear. And before that happens, you need to collect the semen. So here we give sympathomimetics. The best drug to give is ephedrine, which is unfortunately no longer available. So instead, you can give any mixture, any medication that is used for treating a common cold, which has a sympathomimetic in it. So for example, Sinarest has 10 milligrams of phenylephrine, and we'd give that 3 times a day on day 1, 2, and 3, and on the 4th day morning. Combine that with imipramine, 50 milligrams at night on day 1, 2, 3, and on the 4th day morning. And then 2 hours later, the patient would give a semen sample. And very often, this will suddenly change into 2 ml of semen with a very good sperm count. On the other hand, if you have low volume azoospermia and fructose is negative, even without examining the patient, you can be 98% sure that this is a case of congenital bilateral absence of the vasa deferentia. And it's important to bear this picture in mind because I see many patients who've spent years going from gynecologist to gynecologist, being given all empirical medical treatment. When you look at the semen report, and already the diagnosis is clear. Occasionally, in such a case, low volume azoospermia, the vase will be present and there'll be an ejaculatory duct obstruction. So if there is vasoplasia, which is by far the commonest, the treatment would be percutaneous epididymal sperm aspiration with ICSI. And if it's an ejaculatory duct block, sometimes the urologist can do a TUR, of the ejaculatory duct, and suddenly zero sperm count can become 60 million. Now, here is a very common problem. Every meeting, this question is always brought up. How do I treat delayed liquefaction or increased viscosity? So we need to understand this. When semen is ejaculated, proteins in the secretions of the seminal vesicle cause coagulation of the semen. And then over the next half hour, enzymes that were contributed by the prostatic secretion will cause liquefaction. Once the semen is liquefied, it should be possible to pour it drop by drop. But if it is very viscous, you can't pour it drop by drop. That is hyperviscosity, and that is due to alteration in the concentration of the various constituents of the semen. So obviously, altered liquefaction or viscosity will happen if there is an alteration in the secretions of the seminal vesicle and the prostate. Now, very often this alteration is purely idiopathic. You can't find any reason. But if the patient has an infection of the accessory gland, or even if he had a past infection, this alteration can persist for a long period of time. So if there is delayed liquefaction or increased viscosity, it actually can create two problems. The first is difficulty in performing a semen analysis because the semen forms such a thick clump that the lab cannot spread it uniformly, and there's difficulty in getting the correct count and examination of the sample under the microscope. The second implication could be on fertility. It may impair motility. Now I say may because in some cases, despite the delayed liquefaction, once the lab forces liquefaction, they report that the motility is normal. So you can have a patient with delayed liquefaction, increased viscosity, motility is good, no evidence of infection, and there may be no compromise in the fertility of such a sample. And if you do a PCT, which unfortunately most people don't do nowadays, the postcoital test might show good number of active sperm because within the vaginal and cervical mucus are additional enzymes that will cause liquefaction of the semen. If, however, there is altered liquefaction and motility is impaired, then we have two things to do. First, we look for infection. The mere presence of delayed liquefaction does not diagnose infection that needs antibiotics, but it tells you that, okay, check for pus cells, do a semen culture, go into the history of UTI, and if those are present, then you may want to give antibiotics. If there is no evidence of infection, empirically we give mucolytics like bromhexine. Does it help? I'm not sure. I've given it and sometimes people have come back with better reports, but they could even have come back without the bromhexine, but that's something you can do. Often what I recommend my gynecological colleagues to do instead is that, okay, here's persistent delayed liquefaction. After 2 hours, the sample is still not liquefied. Motility is compromised. You're planning IUI. While collecting the sample for IUI, collect it as a split ejaculate in 2 beakers with medium in each beaker. So this will separate the prostatic fluid and the seminal vesicular fluid. The media will prevent it from coagulating. The patient quickly shakes it and your lab processes it, and you will have a much better recovery for IUI. Which brings us to the issue of infection. So this is a common referral again, that Rupin, my patient has good count, reasonable motility, but 15 to 20 pus cells, and they want to know which antibiotic to give or should I do a semen culture first. Actually, neither. 80% of the reports of 20, 30 pus cells are actually wrong. And this is something very important to bear in mind, that there are 3 kinds of round cells in the semen. The macrophage, which you see in the center, is normally present. It eats up dead sperm. To the right, you see the primary spermatocyte, which is shed by the germinal epithelium. It's only the leukocyte, which you see to the left, which is actually indicative of infection. And if a lab just looks at a wet prep without staining the slide, all 3 cells will look the same. So 80-90% of the times when I have a report of high number of pus cells, when I have the sample retested at a lab which will do a proper test, most of the reports turn out to be normal. And this is very important because otherwise you'll keep on giving antibiotics and more antibiotics, and the pus cells will never go away. In fact, the WHO manual specifies that the lab should use a peroxidase stain, and only those cells that stain with the peroxidase are to be counted, and if there are more than 1 million per ml of such cells, only then is a diagnosis of leukocytospermia to be made. If there are genuine pus cells, then how do you treat them? Usually I would first give a course of doxycycline because it's difficult to diagnose chlamydia mycoplasma. After 15 to 20 days of doxycycline, during that period, regular ejaculation, we retest the semen. If the pus cells have gone away, then we would make sure that the wife is also treated. And if the pus cells are persisting despite the doxycycline, then we would do the semen culture to look for aerobic bacteria and treat those. Which brings us to the next common question, and that is about semen culture. And this is a frequent referral actually from IVF centers, because even for asymptomatic patients who probably don't need a semen culture, the IVF clinic is usually more comfortable doing a semen culture and seeing no growth so that the media is not contaminated. So here is a patient, semen culture done, culture positive, antibiotic given, sorry for the spelling mistake. Repeat culture done, again that's positive, more antibiotics, still positive. Then the patient comes to me, and when I repeat the culture with proper precautions, in 80%, without giving without giving any antibiotics, we have no growth. So what do we mean by proper precautions while doing a semen culture? Very important to prevent the growth of commensals and contaminants. So the patient goes to give a semen sample, carrying a bottle of povidone iodine, betadine, and boiled water or saline and a clean towel. Applies betadine on the penis, on his hands. If he's uncircumcised, pulls back the skin, applies it on the glands. Leaves it there for 4 or 5 minutes. During that time, he passes urine so that the bacteria in the anterior urethra are flushed away. Then he washes it with boiled water, washes his hands, dries it with a clean cloth, masturbates without putting the penis in the bottle. So the squirt goes directly in. And in this manner, the majority of semen samples which are showing positive culture will actually turn negative. If it is still positive, then of course we give antibiotics. Sometimes we'll need to give parenteral antibiotics. And we have rare cases where whatever you give, there is a persistent growth of nasty bacteria, Klebsiella, Pseudomonas, E. coli, and the coupleless planning IVF. And this we see often in paraplegic men where we have done electroejaculation, or men with a past history of chronic prostatitis. And in such cases, in fact, we have preferred to take sperm aspirated from the testes because those sperm are free of all bacteria, and that sample is used for IVF rather than using a sample from the ejaculate where there's a risk of bacteria and pus cells. So I'll just check the time available. Yeah, maybe another 5-7 minutes. The talk actually goes on for an hour, but we don't have enough time. So we'll cover whatever we can, and then whatever is remaining can be covered during the questions. Now, this is a common problem again. Rupin, patient has good count, good motility, but 90% are abnormal. And the patient has been told that these abnormal sperm are the cause of infertility, they're the cause of the past 2 recurrent abortions, and the patient wants to know whether he's going to have a double-headed child, a Ravana maybe with 10 heads. The strange thing is this is actually a normal semen report. Very important to get this point because too often I find gynecologists getting very disturbed by such a report. So what's happening here? With the latest WHO manual 2010, the strict criteria for sperm morphology were adopted. Now, in the old criteria, sperm was presumed normal unless there was an obviously detectable abnormality. By strict criteria, every sperm is presumed abnormal unless it meets up to every criteria of diameter, width, length, tail, midpiece, etc. And by strict criteria, even in Normal samples, you may have 90-95% abnormal, and up to 4% normal, which means 96% abnormal, is considered a normal report. So if you're having your semen analysis from an IVF lab or a specialized lab, it's quite possible that you will see a report with only 5% normal, 6% normal, and that should not worry you. This table just shows how over the years, lots of things have changed in the WHO norms. And the most dramatic is morphology. In 1980, 80% of the sample had to be showing normal sperm, but in 2010, only 4% normal is considered to be normal. And therefore, if you're seeing a semen report from a very good lab, 95% sperm are abnormal, do not worry. That is not the cause of the problem that you're facing. If it's less than that, only 1% normal, 2% normal, then that becomes an indication for IVF ICSI, though there's some controversy even there. Now, very quickly, a few aspects of treatment before we run out of time. So this is again a common question that I'm asked. Rupin, I'm treating a case of idiopathic oligoastheno FSH-LH on the lower side. Can I give this patient clomiphene or tamoxifen or gonadotropins? The problem is that most gynecologists do the same hormone profile in men that they do in women, which means you look at FSH, LH, and prolactin. Prolactin is irrelevant in men. The third hormone that you should look for in men is testosterone, because you can have two very different situations. Two men, both with low normal FSH, LH. In one, the testosterone is also low, 230, but the one to the right, testosterone is very high. So the guy on the left, low testosterone, low gonadotropins, yes, he may benefit from clomiphene 25 milligrams every day, or tamoxifen 10 milligrams twice a day, or you may want to give gonadotropin injections, though they are not superior to the aromatase inhibitors or the estrogen receptor blockers. On the other hand, the man to the right, his testosterone is 640, and that is the reason why by feedback FSH-LH are low. This testis is adequately stimulated. There is no role for hormone therapy. So FSH and LH always have to be interpreted in the light of testosterone, and only when you have low testosterone and low normal FSH-LH, those are the men. Those are the men whom you will treat with hormone therapy. Niranjan, whenever you want me to stop, just interrupt. Now, this is another common dilemma, and this one I would like to complete because I see time and again. You have a patient with oligoastheno, send him for a Doppler ultrasound. That reports a grade 3 left varicocele, a grade 1 right, and now you don't know what to do. And if you ask me what should I do, I would tell you I don't have enough information. I cannot give you an opinion. The most important piece of missing information here is the clinical finding, because it can very well happen that clinically I don't feel a varicocele at all, but the ultrasound picks up significant reflux, and that is not significant. So here is a recommendation of both the ASRM and the AUS stating that only palpable varicoceles, which means clinically detectable varicoceles, are associated with infertility and need to be corrected. And therefore, ancillary diagnostic measures, which means a duplex ultrasound Doppler, should not be used for the detection of subclinical varicoceles. The problem is most gynecologists do not examine the patient, so they refer for the Doppler, but it doesn't help because that is not a substitute for clinical examination. If on examination, I'm very sure there's no dilatation, no tortuosity, then picking up reflux on the duplex ultrasound is not an indication for surgery. And therefore, the answer to the question that should a patient with reflux on ultrasound be operated will also depend on the clinical finding. And if there's a clinical varicocele and there is reflux confirmed on Doppler, yes, then such a patient can undergo surgery with a 50-60% chance that there may be significant improvement. One last two questions we look at quickly since no one is interrupting. And that is, how do you manage oligoastheno? Commonest case you will see, 80% of your patients will be oligoastheno, maybe teratozoospermia. And actually, you need to consider lots of factors to manage them correctly. That's a 1-hour talk in itself. We will not go into that, but just 1 or 2 important points. First, bear in mind that semen analysis is only a rough indicator of a man's fertility. So just because a man has come with the first semen report showing 5 million, do not label him as infertile. Many men will surprise you. This is a wonderful study done, which showed, for example, that if a man has only 1 million motile sperm, but he has been trying since only 1 year, so young couple, short trying time, he still has a 25% chance of a natural conception in the next year. The same man, however, if he's been trying for 4 years, the rate of pregnancy is half, only 14%. And the other way around, somebody with a much better sperm count, 10 million actively motile sperm, but infertile for 96 months, 8 years, the chance of pregnancy is very low at only 14%. In other words, you don't look at semen picture alone. You have to look at the totality, age of the male, age of the wife, duration of infertility, trying time, and whether they've had previous therapy. So with the same semen picture, the couple to the left, you could certainly give all kinds of medical treatment, whatever you want, for 3 months, 6 months, 12 months, while simultaneously optimizing the wife's fertility. And 1/4 to 1/3 of these couples will achieve a pregnancy despite the oligo. On the other hand, the couple to the right comes to you for the first time with a thick file, lots of semen reports, lots of therapy, nothing has changed, no pregnancy. Do not waste time just because he's come to you for the first time. This couple needs to go in directly for ICSI. Now, which drug do you use? This is a question everybody wants to know. Even the sponsors of the meeting want to know. Well, you have a huge range of products. And the truth is that if you go through literature, every drug listed as some studies showing that it helps. But if you look at large Cochrane analysis, generally the benefit is very nominal. Even for antioxidants, while concluding that it will improve birth rates, the evidence is still considered low quality, and no single agent has been shown to be superior to any other. So yes, you can give treatment depending on the age. For young couples, you're giving treatment to buy time and maybe improve the semen. But for older couples, don't waste time giving medical therapy. And remember, don't waste too much time or money. So if you have a poor patient, don't give him very expensive combinations. Simple vitamin E, vitamin C will work. But for others, yes, you can try whatever you want to. The do no harm is mainly a reminder that do not give injectable testosterone, even if the testosterone level is low. If you give an infertile, subfertile male testosterone, his sperm count will drop further. I'm going to end with this one last mention of azoospermia, which is actually a 2-hour lecture. But I'm often asked, Rupin, what do I do for this patient? He is azoospermic, he has a small testes, FSH is elevated, so I know it's testicular failure, but the couple doesn't want donor sperm. So is there any update? Is there something new that can be offered to these patients? And yes, there is something new. In the past, we either thought patients had testicular failure, that's to the left, and they have no sperm at all, or they have many, many sperm and they have obstructive azoospermia. We now recognize that there is an intermediate group who have testicular failure, who have azoospermia, but who still have a few sperm in the testes. But these sperm are not coming out because the overall production is very few. And anywhere between 20% to 50% of men with Sertoli syndrome, testicular atrophy, maturation arrest, may have some sperm in the testes, which can be retrieved by doing multiple biopsies or microtessay, and successful pregnancies can be achieved. And you can find sperm even if FSH is very high. 30, 40, 50 FSH, we found sperm, even if testes is very small, like the size of the pea. And even in men who had mumps orchitis, bilateral orchiopexy, chemotherapy, and now have azoospermia, in 40 to 50% of such men, we can find sperm. So, of course, there are many, many, many more topics to talk about, astheno, DNA fragmentation, etc. But I need to conclude here by pointing out that male infertility is an essential component of your treatment of an infertile couple. Do not focus only on the wife. Make sure that you have at least a proper semen analysis. Draw some conclusions, and if you are in doubt, have somebody proper examine and treat simultaneously while you are treating the female partner. So with this, I'll stop the talk, and I believe questions are going to be at the end of the session.
Yes, yes, sir. It was a wonderful presentation. There are many questions which have come. I would like to reiterate here. We have got 1,500 users online, and they have been nicely hearing from you. Before we go to our next speaker, Dr. Rishikesh Pai. Sir, after your talk, I remember of the film Vicky Donor, and it has to be mentioned here on a lighter vein. You know what he said about the selection of sperm. ये काम लीगल है, आज से ही नहीं, महाभारत के टाइम से है. And from that day till today, doctors have progressed to the art of, sperm selection. And so now we have with us none other than Dr. Rishikesh Pai, who is going to talk about sperm selection and what is its role in IVF. Dr. Rishikesh Pai, please go ahead. Welcome.
Can you hear me, Niranjan? Can you hear me, and can you see my slides?
Yes, we can
Okay,
hear
great.
your slides.
Thank you. Rupin Shah has been a very good friend of mine. We have worked together, and he's our principal andrologist for the Bloom IVF group, and he goes to many other doctors. He is a very leading person whenever I talk to my patients, I tell them that he is the leading andrologist in the world, so I really respect him and his work. So what I'll be talking to you on a different perspective. You need to know a little bit of what's happening in the field of the sperm. And see, I'll be dividing my talk into these 7 headings: ICSI, selections, injection, freezing, micro-TC, spindle transfer, CRISPR, and sperm production. So if you look at it historically, the first ICSI was done in 1992, and actually it was a mistake because prior to that there used to be a technique called SUSI, subzonal insemination, and Hugh Joresh, who is my very good friend, and Palermo were doing research, and one fine day SUSI was done by Hugh Joresh in the lab in Brussels, and out of the 12 eggs, the next day only one had fertilized, and the one by mistake, instead of putting the sperm under the zona, he had by mistake injected it into the cytoplasm, and that was the only egg that had fertilized. So Dr. Palermo, when he was analyzing the results of the lab the next day, he said, "Arey, what is this? Only one of them got fertilized," and that's how ICSI was accidentally discovered. So it was an accidental discovery, and the second part of the ICSI was it jumped directly. There was no animal experimentation. ICSI was one of the techniques that jumped directly into clinical application. I went for the first workshop in Asbub in 1995, and we were the third in India to start the ICSI procedure, and with my colleague Nandita Palcherkar, Sudesh Kamath, and Shaunak Khandwala. Our first ICSI baby was born. It was actually from Delhi in 1996. And then the whole thing came in. I brought in a lot of technologies. I was really obsessed with the male factor. If you see the indications of ICSI, the male factor is the main indication to severe oligozoospermia, asthenozoospermia, teratozoospermia, retrograde ejaculation, sperm antibodies, serodiscordant males where husband is HIV positive and wife is HIV negative. In oncology, when you thaw the frozen sperms in these males, many of the sperms are grossly impaired, and you may have to carry out ICSI on these. Ejaculatory dysfunction, paraplegic males, azoospermias, obstructive as well as non-obstructive. This is the male factor, but there are other indications which I call the non-male factor indication. So if there's a previous failed fertilization, we do ICSI. We can also do, as Jaideep Tank had said, we do a lot of oocyte activation for previous fertilization failures with ICSI. We use ICSI for pre-implantation genetic diagnosis. We use ICSI on in vitro matured oocytes. We use ICSI on frozen thaw oocytes, and also in clinical conditions such as advanced maternal age, poor responders, unexplained infertility, patient with endometriosis, and many units in the world are using ICSI for all. So even if the count is normal, instead of doing IVF on these patients, they do ICSI. And then there are 3 experimental areas which I will talk to you about. the mitochondrial spindle transfer, the CRISPR, and creating sperm from somatic skin cells. So in ICSI, you do stimulation as we do use the antagonist protocol. We do the oocyte retrieval, and after the retrieval, what we do is we do sperm processing, and the processing is done by 2 steps. Either we can do it by the standard swim up method, or we can do a density gradient method. So these are the 2 steps which we use, and then we use these sperms and we do the injection of the oocyte. So if you look at the ICSI, once the oocytes are retrieved, we use the flushing media and we dissect the oocyte. So the oocyte is covered with cumulus cells, and we use mechanical dissection as well as hyaluron rays to actually dissect the oocytes and create a bare oocyte. Once that is done, so you can see here the oocytes are being dissected by one of my very good and close friends who has probably injected maybe 300,000-400,000 eggs. I don't know how many he has injected, Dr. Sudesh Kamath. And then when we dissect these oocytes, we ultimately make them bare. And so we use pipettes of varying diameter, 170 micron pipette. Following that, we use a 140 micron pipette. And so slowly we dissect the oocytes and make them bare. Once these oocytes are made bare, you can see now they are totally devoid of any cumulus cells. After that, we put them in the droplets. And so you can see these are the denuded oocytes that are put in small droplets. You can see these small droplets. In each of the droplet, an oocyte is put, and in the center, the sperms are put. And these sperms are then immobilized using an injection pipette. This is a 7 micron thickness injection pipette, and you have to cut the tail. My friend Dmitry Dordostev, he is now in United States. He did this research project where he showed that by cutting the tail, you release the sperm oocyte activation factor, and that is very essential for achieving fertilization. So once you hold the oocyte, you hold it in with the polar body at the 6 o'clock position. The polar body is where the spindle is, and you don't want to damage the spindle. And then you bring the sperm directly very near the tip. It's very important not to inject too much of media into the oocyte. So you can see he will bring the sperm very much near the tip, and then he will inject. So there he tends the cytoplasm, injects it, he mixes the sperm, and then he deposits the sperm into the cytoplasm. So this is the ICSI technique. And now if you look at the fertilization rates in ICSI, they are nearly 60 to 70%. An egg damage rate should not exceed 10%. And on an average, in 3 attempts of ICSI, nearly 90% of people in our units, they go take a baby home. So the live birth rate, I would say, is around 30 to 40% per embryo transfer. So Paul Devroy. So there were 4 people who did ICSI together. It was a group. Paul Devroy, Von Stiertegem, Palermo, who was the discoverer of ICSI, and Hugh Joris, who was the actual embryologist who injected it. And they had a lot of publications which came out, and he concluded in 2004 that the success of ICSI is independent of semen parameters. It is not affected by maternal age. You need to gently and vigorously mix the cytoplasm with the sperm. Aggressive mobilization of sperm will increase fertilization rate, and disruption of oocyte is sufficient to cause the oocyte damage. Demise should not be there. So if you look at it, can we improve the success rate in ICSI? Can we improve it by selection of appropriate sperm, which is the hallmark decision-making point of ICSI procedure? And that's where the selection comes in. So the main moot question was, are there techniques that can select spermatozoa with reduced levels of chromatin or DNA damage? And that's where the various selection techniques came in. Danny Sakas is a brilliant embryologist, and in 2013, he wrote a brilliant article in Fertility Sterility, which I had the fortune of reading. And he divided the selection methods into 4 areas: improving sperm quality by semen preparation, surgical sperm retrieval, individual sperm selection, and also experimental techniques. So if you look at the improving sperm quality, the most important is double density gradient. And this is a very good method and it can be used in all sperms, like normal sperms, sperm with oligoasteroteratospermia, sperms with DNA fragmentation, sperm with increased reactive oxygen species. All these kind of semen parameters can be used by double density gradient, while microfluidics and magnetic assisted cell sorting, which we do in our lab, can be used for specific groups. So if you look at the magnetic assisted cell sorting, which we do, it is used for deselecting of apoptic sperm. So It's very effective in normal sperms, oligospermia, teratospermia, high DNA fragmentation. All kinds of sperm except the astenospermic sperms can be used with this technique. We have got very good results with this technique. This is a technique. I don't have the time. I just wanted to give you an overview of what we are doing on the lab side as well. The second technique which we use is the microfluidics. It's a superb technique which is there, and it eliminates sperm damaging procedures associated with sperm washing, swim up, and gradient centrifugation. And you can use it for a lot of sperms. You can see that there's a chip. You load the chip, and within 30 minutes you get a very good sperm sample. And we are using it for a lot of our failure patients. Then we can also do surgical sperm retrieval. There are many patients who have repeated ICSI failures and they are having a high DNA fragmentation. These are the ones where you can actually go into the testes and do PISA, TISA, whatever. That's Rupin Shah's area. We just want to get the sperms. He does it for us, and we get the sperms and we inject them and get fantastic results. Then what about individual sperm selection? So there are certain techniques which individually select good sperm, and these are classified into IMSI, then PIXI, then host and sperm head bifringes. So in IMSI, what we do is that we look at the various parameters of the sperm. So normally, if you look at ICSI, we do ICSI at 2,200 times magnification, but the IMSI is done at 6,600 times magnification. And you can see here, it's just similar to what I showed you in the ICSI technique. But in this, what we do is that we magnify the sperm, we immobilize the sperm, and then we measure the length of the sperm head, we measure the breadth of the sperm head. As Dr. Rupin Shah told you, that we use the Kruger strict criteria. And using that strict criteria, we look at vacuoles, how many vacuoles are there within the sperm head, what is the diameter of the vacuole. And so using this criteria, you can actually select a very good quality sperm. And especially in patients with repeated ICSI failures, this is a very good technique. So you can see here, we will immobilize the sperm first. So in abroad, they used to do the measurement in real time with the sperm motile. What we do is we immobilize the sperm first and then we do the measurement. So with this reverse technique, we can do the whole procedure in 15 minutes flat. So you need two embryologists, one who actually immobilizes the sperms and the other one who actually quickly measures the sperm head length and breadth and picks up the good quality sperm and injects it. So this is how we do the IMSI technique, and it has got very good results. Though there was this Teixeira's meta-analysis which showed a good outcome as far as clinical pregnancy rate is concerned, but there was no significant difference in outcome as far as the live birth rate and miscarriage rate was concerned. So IMSI enables selection of sperm with normal nuclear shapes at high magnification. This is positively associated with pregnancy rates, especially in teratospermia, couples with previous and repeated implantation failure, high degree of sperm DNA fragmentation rate, repeated poor quality embryonic development in an ICSI cycle and an aging male. Some other techniques are, you have got PIXI where you have got plastic dish, and you have got hyaluron one which is there implanted on the plastic dish. So the sperm which are normal have got a good hyaluron expression, and it can go and actually attach to the plastic dish, and those sperm that are attached are picked up and we can do ICSI with them. And there is another test which is known as hypoosmotic swelling test, where actually, whenever you take out the sperm from the testes, you don't know, many of them, they are immotile. They may be live or dead. So you, by exposing them to hypoosmotic media, you can find out which are the live sperm. The sperms with the curling of the tail are the live sperms. And in those sperms, you can actually pick up and inject, knowing fully well that they are immotile. But because the sperm tail has curled, you know that this must be a live sperm. And we get a lot amount of patients pregnant with this kind of technique. This is a paper by Greco in 2005 where he showed that the pregnancy rates of using testicular sperm versus ejaculated sperm with a pathological DFI were compared in couples with repeated IVF failures, and he showed that TISA-ICSI significantly improved clinical pregnancy rates in these couples. Then the third area is sperm injection. So coming to the technique of injection, there is not much difference, but there is, what we brought in was the poloscope. Initially, I brought the first poloscope in 2006 that was called spindle view. But the problem with that was that the spindle could be visualized only when the temperature was very steady. So it was very temperature sensitive kind of technology. And we were not happy, and actually we put it back into the cupboard. It's still lying there in my cupboard. It was a very costly technology, like a white elephant, but we could actually see the spindle. And so in many embryos, sometimes many of the eggs, there is a shift in the spindle, and if you can visualize the spindle and you can avoid the spindle, that was a great technology. But because it was not that great, we again bought a new technology called spindle check technology, which was bought by us 1.5 years back, and that is a breakthrough technology because you can see the spindle beautifully. You can see this is a white spindle. Normally it is near the polar body, and you can see this spindle. You can see here in this video at around 11 o'clock position, the spindle is there, and it is beautiful because it has got tremendous application now. This particular technology is a breakthrough technology, and its application I will tell you in the other next part of the talk. You can see the white. It is beautifully seen throughout and this is you see using optics. Now you can also cut many times these eggs have got a very thick zona, so you can actually use a laser to cut it and then inject the needle into the oocyte and to facilitate better sperm injection. Then, of course, the next is a micro TC, and as Dr. Rupin is here, he is our micro TC man. Normally, if there is an obstructive azoospermia, it's very easy to get the sperm from the testis. You just stick a needle in, and most of the time you'll get the sperm. But it is the non-obstructive azoospermia where Dr. Rupin initially would go do a simple TC and see if we can get sperm. But if he can't get the sperm, then under operating microscope, he does a lovely job, and you can see that he magnifies the tubules that are magnified. He picks up those tubules. It's a very meticulous process, takes a long time, but you will see that nearly in 40 to 50% of our patients who we fail to get sperm with normal testicular biopsies, we get the sperm with micro TC and get a lot of patients. We can achieve a lot of pregnancies in the patients. The next thing, which is a breakthrough technology that has come in last year, is the single sperm freezing technology. And normally what happens if you have 1 or 2 sperms, how do you freeze those sperms? There was no technology available, and suddenly this breakthrough came from Israel, where you can actually pick up single sperm and vitrify it. And we have started using this technology. I was very thankful on one evening that couple who had actually discovered this technology came to Mumbai, and that's the advantage of Mumbai. All the people come to Mumbai all the time, and in the evening on a dinner I saw this technology and I went back and I was so impressed. I told my employees, get that technology, and I'm very happy to tell you that first sperm injection done by Dr. Rupin in Gurgaon. Our pregnancy patient is pregnant now and she's 20 weeks. So even if there are 2 sperms, so you know what happens that in many patients of non-obstructive azoospermia, if you do extended search, it is known as extended search. You need to search these semen samples for as much as 2 hours, and you may get 1 or 2 motile sperm. Those are picked up, and using this device, you can freeze them. So multiple extended search can be done. You can accumulate the samples, and then you can use them. You can do the oocyte retrieval, thaw these sperms, and you can use them for injection. Then we have the spindle transfer technology. What a beautiful new breakthrough that came. And you must read Dr. Nuno Costa Borges, how he evolved this technology. And I hope that I can do this. I can replicate his, as soon as this COVID infection is over, I'm going to go in for replication of this technology in India. So this technology, how we first started it in the mice, how we evolved it, how he took the permissions, how ultimately he came to the human. So in this technology, what you do is that if there are patients with aged oocytes, in that the DNA, that is the spindle, is intact, but the cytoplasm is depleted of mitochondria. So what we do is we take donor oocyte and I showed you the spindle check technology just now. Because we can now easily see the spindle, we enucleate the donor oocyte and remove the spindle from the donor oocyte. Then we take the spindle of the patient. So we have to freeze the oocyte beforehand. In the previous cycle, we thaw the oocyte and we'll remove the spindle from the patient and we'll put it into this enucleated donor oocyte. And then we fuse this together to create a new oocyte with the cytoplasm of the donor and the DNA of the patient. What a fantastic idea. So you actually maintain the DNA. The biggest problem with this technology was the fear of imprinting disorders, which has now, so Dr. Nuno Costa got the best prize for his landmark paper. He first did it on mice, demonstrated it, then he did it on humans, and now first baby was born in April of 2019, and now 14 ongoing pregnancies are there. They are still waiting for the long-term effects, whether they are there on the children, and then this technology will be released to the general public. The next technology, which is again a brilliant technology, is the CRISPR technology. So what is CRISPR? Clustered regularly interspaced short palindromic repeats. And this technology was invented on a cup of coffee in Brazil in a conference by Emmanuel Charpentier, Jennifer Doudna, and Feng Zhang. So what did they do? So you can actually modify the gene in suppose you have got a hemoglobin, so you have got a patient with thalassemia. You can actually take the sequence that's called a target gene, and you can create a complementary RNA and target RNA using a library. So you can go to the gene bank and you can actually pick up the sequence. Once that is done, we assemble a system. It is known the Cas3 Cas9 protein system, which is used by bacteria. So bacteria uses this system regularly to kill the viruses. So the Cas3 Cas9 protein system is attached with the sequence, and this goes and you can then do ICSI. So using ICSI, you can inject this sequence into the embryo, and the system will go directly to the gene which is to be targeted. As soon as the RNA attaches to the gene, the Cas3 Cas9 system has the endonucleases protein which activates and cuts the gene. So this is how we can actually modify the gene. And in the future, there'll be a lot of CRISPR can be used for especially autosomal dominant disorders. So in an autosomal dominant disorder, all the embryos will be abnormal. You can't have a normal embryo. In those patients, especially if the mother, husband, and so in those patients, you may be able to use CRISPR. And then finally, I would like to tell you about the sperm production from stem cells. So this has been always, this was a fertility sterility article in 2014. And, that time I thought that, okay, it's a theoretical thing. And then what happened is that recently in 2016, in the US journal Cell Stem Cell, Jiao Shah of Nanjing Medical University and Xiaoyang Zhao of the Chinese Academy of Science, they created history by taking the embryonic stem cells from the mice and they exposed it to chemical cocktail, and they coaxed this embryonic stem cell to turn into primordial germ cells, which they mimic the natural tissue environment of these precursor germ cells by exposing them to testicular cells as well as sex hormones such as testosterone. These embryonic stem cells derived primordial germ cells underwent complete meiosis till now. So they created a meiotic division because there was a lot of technology to convert normal somatic cells to 46 chromosomes, but the only two cells in the body which have 23 chromosomes is the sperm and the oocyte. So they had to create a meiotic division, which they achieved. And after that, they achieved these spermatids, and these sperm-like cells they injected into mouse egg cells and created embryos which they transferred into female mice and produced actual mice. So the problem in using embryonic stem cells is that many countries in the world, because they are religious, Catholic religion is there, they don't like to handle embryos. It's against the Catholic religion. And so there has to be an alternative created. And that alternative is known as iPSC. It is known as induced pluripotent stem cell. So we can't take an embryo and create things. So we have to have some other stem cell. And this is called induced pluripotent stem cell, which is from the somatic skin cell. You convert this somatic skin cell into a stem cell. And this landmark work was done by Shinya Yamanaka and Katsuyoshi Takahashi of Japan. They took the skin cell, they injected it using the same micromanipulator which we use for ICSI with 4 genes. These are known as transcription factors. And they reversed the stem cell. So they took the skin cell and they reversed it back to the stem cell by injecting these 4 gene factors, and for that they got the Nobel Prize. In 2012, the Nobel Prize for Physiology was given to Shinya Yamanaka for this landmark work, because there are 46 transcriptomic factors and they could identify the 4 main transcriptomic factors which were necessary to reverse the cell and make it into a stem cell. And for this, they won the Nobel Prize. And then what they did, they converted this pluripotent stem cell into primordial germ cell using exposing these cells to a complex chemical bath. This primordial germ cell conversion to mature functional oocytes was carried out in presence of fetal ovarian tissue by Hayashi in 2016. He published his work in Nature Research, and this conversion of PGC to oocyte followed by they did a ICSI on these patients. They did a ICSI on this patient, and they could get the. Sorry, I'm just put the timer. They could get the ICSI on these new oocytes that were there. They did injection, did micro injection, and they created pups, and these pups were then given. So, but at the same time, in 2016 in China, there were another group which converted the induced pluripotent stem cells into spermatids. And this they injected and they created mice from that injection. And recently in 2016, Carlos Simone, but this work was done in mice, but the first conversion of human skin cell into spermatid has been done in Valencia in association with Stanford University by Carla Simone in 2016. And so in the future, what we are going to have is we are going to be able to create a lot of human eggs. We are going to be and sperm from just skin cell. There will be no oocyte retrieval, no ovum pickup, no testicular biopsy. This will be then injected. The problem is the efficiency is less. So when you create these oocytes from skin cell, suppose you inject 100 of these oocytes, you will have about 3 or 4 embryos only. So the efficiency presently of this technology is less, but slowly the efficiency will go up, and then you can actually do pre-implantation genetic diagnosis to take the biopsy, look for abnormalities, look for imprinting disorders. You may use CRISPR to modify these embryos. If there's a abnormal gene for diabetes, cancer, you will be able to modify that gene, and then you will be able to transfer the babies back into the womb. So this will be the future. 40 years down the line, IVF will be the preferred choice of having babies. You may have sex for enjoyment, but you will have IVF for procreation of ideal children. And this is the evolving concept of unibaby. These are the mice that were born, first mice that have been born from the oocytes that were being created from the skin stem cells by the Chinese group. And this is Azim Surani, the biologist from Cambridge, has said each cell in your body is a potential gamete. Just think about it when you go to sleep today. Thank you very much.
Thank you, Rishikesh Pai. You have taken, I think, 100 years beyond the time of 2020. I think you have covered everything of CRISPR, about the studies which are done in the mice, and there are so many things which you have said, and the users have swelled now to more than 1800 after your lecture being heard, and there are more than 200 questions to both of you, but I will just filter them.
Niranjan, ask the questions mainly to Rupin. I mean, I'm sure they will be. I consider Dr. Rupin as a very great person in this field, and we are very happy to be working with him. So I think you should direct more of them to him, because people are very interested in the male part of it. We are, of course, there to supplement him.
Thank you. It was a wonderful presentation by both of you, and there are many questions. I will go one by one. For poor semen analysis, low count and poor motility method, what is the semen preparation? Saloni Gupta is asking for poor semen analysis, low count and poor motility method for semen preparation. And what is the role of DNA fragmentation of sperm? Dr. Rupin, can you please unmute your mic? Thank you.
Have I been unmuted?
Yes.
So how to prepare the semen, Rishikesh will answer that, because that goes back to the lab. DNA fragmentation is interesting because there are studies that showed that irrespective of the semen analysis, the DNA fragmentation index was more predictive of fertility. So you would think that DFI should be the test to do. However, there's a huge variability from test to test, lab to lab, even in the same patient, with cutoff points. And even patients with high DFI may sometimes achieve a natural pregnancy and vice versa. So because of all these uncertainties, it's still not universally advised. It should be done in patients with multiple IVF failures, idiopathic infertility, early pregnancy loss.
Sir, you said early pregnancy loss. So how many? 3 early pregnancy loss? Dr.
No.
Sanjeev Kurd is also there from Pune. He wants your view on DNA fragmentation.
Yeah, so if there are a couple of pregnancy losses, then we would look at DNA fragmentation.
Sir, Dr. Baswaraj is asking the dose of methotrexate, does it work in azoospermia?
Methotrexate.
Yes.
Why would you give methotrexate in azoospermia?
Is there any drug used to increase the motility of sperm? Dr. Meera Gupta is asking you, sir.
Is there a drug that will improve motility? No, but are there drugs that we give these patients? Yes, because a lot of treatment of male infertility is an act of desperation. So for motility, carnitine, coenzyme Q10, those are the main agents that we would use in an attempt to improve motility.
Okay. Sir, Dr. Varsha Baste from Nasik, she is our Foxy chairperson. She would like to ask, kindly elaborate the treatment of erectile dysfunction.
Another 1 hour lecture. So, but it's an important question. The gynecologist will encounter erectile dysfunction, especially in couples trying for a child in the peri-ovulatory period. And what you should be aware of is that you can give these men sildenafil 50 milligrams 1 to 2 hours before intercourse. It is safe, it will not harm the sperm, nor will it harm the partner. So couples often wonder that, doc, can we take sildenafil when we are trying for a baby? And the answer is yes. Now, if sildenafil doesn't work, you can go up to 100 mg. If it still doesn't work, then you need to refer to a urologist.
So what are the contraindications for sildenafil?
The only real contraindication is somebody who is using nitrates, because sildenafil or tadalafil will cross-react with any oral nitrate to cause severe hypotension. But otherwise, a man with diabetes, hypertension, or any other medical problem can take sildenafil.
Okay. Sir, what is the role of antioxidant treatment in male factor? So we have got many, Ayurvedic medications which are there. And as you said, there are various drugs which are given like selenium, zinc, chromium, calcium, and then newer things are just coming up. So what do you think? Do they really act or do they really work? And for how much duration we should give? This is Dr. Manisha who is asking you.
Sure. So if you look at large studies, meta-analysis, there are some that have concluded that giving antioxidants improves pregnancy rates, and others that claim it doesn't matter. Currently, the concept that a whole group of andrologists is working on is that men with oligoastheno fall in 2 groups. Those who have high levels of reactive oxygen species, and those are the men who probably will benefit from antioxidants, and those who have normal ROS levels who will not benefit from antioxidants. And in fact, if you give too much of antioxidant, you can even harm the patient's fertility. So does it help? Yes. Will it help everybody? No. How do we identify whom to treat? At present, we can't, because we don't have routine access to ROS measurement. Otherwise, that would divide and identify the patient groups. How long do you give the treatment? You should give it for 3 months. And that's an important question, because often I see prescriptions for 1 month, do a semen test, come back, and you don't see any change in 1 month. So give the treatment for 3 months, check the semen at 3 months, and if there's improvement, continue for 1 month more and see a semen report a month later. And if there's improvement, continue further. If there's no improvement, change the drug.
Thank you.
Which one to give? Poorer patients, I will give something very inexpensive. Vitamin E, vitamin C, maybe lycopene. Cost them about 10, 12 rupees a day. Those who can afford it, they can have the more expensive combinations with coenzyme, carnitine, and everything else. Herbal preparations, not yet well proven, but you can give it as one of the options if everything else has failed.
Thank you. Dr. Rishikesh, we come back to you. How OHSS is identified and treated? Please tell us about agonist and antagonist when they are used.
So I think it's like a tangent question, but before I answer that question, again, I would like to say that in our unit, we have 4 techniques of semen preparation. Swim up is there. We have double density gradient. We have got microfluidics, and we have got magnetic assisted cell sorting. And I am about to introduce a new technology called nanoparticles. And we also have IMSI in our units. So if we are to do a standard swim up, if the so double density can be used for every kind of sperm, normal sperm. For a standard IUI you can use it, or you can use a swim up for oligoasthenoteratospermia, DNA fragmentation, patient with high reactive oxygen species, all of them you can use double density. Microfluidics is also very good technology. We can use it for everything except patients with high DNA fragmentation. And the magnetic assisted cell sorting we are using for, you can again use it for every type of patient, normal or abnormal sperm, except for astenospermic patients. So that is as far as the sample usage is concerned in our lab. As far as the hyperstimulation is concerned, and the stimulation protocol, we have given up using GnRH agonist long protocol about 5-7 years back. When I was using the long protocol, my pregnancy rate was 7 to 8% higher than the antagonist protocol. But I made a conscious decision because I felt that pregnancy rate is not that as important as the safety of the patient is. There should be no hyperstimulation in our unit. There should be no death in our unit. And hence we consciously, though if you look at the meta-analysis and Cochrane report, the pregnancy outcomes are same with agonist and antagonist, but in actuality it's not the same. In actuality, the GnRH agonist gives a better outcome because the number of egg yield is higher with GnRH agonist. So, but because of the safety issue, I have stopped using it, because safety first. There are 2 things in medicine. You must remember Latin. Unfortunately, we are not taught well in our country. There are 2 things which you must remember. One is called beneficence and one is called malfeasance in ethics. Beneficence means you have to ask the question, whatever treatment I do, will it benefit the patient? That is the first question you have to ask. And the second question you have to ask, malfeasance. What is the treatment? I should not do harm to the patient. That's called malfeasance. So you must always ask these 2 questions, and whichever gives the best answer, you should practice that in your whatever you do in your life.
Dr. Rishikesh, you took us back to first year and second year MBBS by telling those words, and especially trying to improve the ethics of infertility practice, and that is what is very important. There are many questions which have come. I would like to ask you one more question, Dr. Rishikesh. What is the main reason of degeneration after ICSI in human oocytes?
The main reason is technique, and that's why you will be surprised that my friend Alpesh Doshi was telling me, and that if suppose your injection rate, and this is for all the embryologists who are hearing it, in United Kingdom, if your egg damage rate goes more than 10%, they send you back to school. You have to go back to the mice lab, you have to practice, and you have to get back your egg damage rate to less than 10%, and then only they allow you to come for clinical practice. In India, it is not like that. We don't have that rigorous establishment, but damage rate should not be more than 10%.
Thank you. Dr. Rishikesh, wonderfully explained. I will come back to you. Dr. Rupin, we have got 10-15 questions lined up, but I will just filter them. This question is, does varicocelectomy improve the DNA quality of sperms?
Yes, varicocele surgery will lower DNA fragmentation rate, but the extent to which it is lowered remains controversial. Many studies have shown that DNA fragmentation will go down by 3 to 7%. So it lowers it, but is that clinically significant? So if you have a patient with high DNA fragmentation, say 50 or 60, the treatment will consist of lifestyle change, stop smoking, lots of antioxidants, etc., and correction of a varicocele if there's a clinical varicocele. So yes, we would correct the varicocele, but the benefit may not be dramatic.
Sir, I recollect when I'm sitting in the OPD, the ultrasound report of the testes comes as grade 1 varicocele of the right side or the left side, grade 2, grade 3. So then we interpret it. How do we go about and which will go for surgery and which will go for medical line of treatment, and what, like we examine also the testes, the and ask the person to cough, try to palpate the uh, the snake like feel which we get just above the testes to bag of worms, and then we try to assess, and then we have an ultrasound Doppler study which is done. Now if it is grade 1 and 2, so clinically, and we correlate with ultrasound, or we refer to the urologist for a surgery to be done, or treat her medically. So that is a very defining point for us.
So you will treat a patient with varicocele initially the way you would treat a patient with oligoastheno. In other words, if the couple is young, short duration of trying time, even though they have a varicocele, it is justified to give medical therapy. Medical therapy may consist of antioxidants or clomiphene. And about 25% of men who have varicocele and oligoastheno will achieve a pregnancy during conservative management. If in 3 to 6 months of conservative management in a young couple, there has been no improvement, no pregnancy, and the patient has a clinical varicocele of any grade, then you can consider surgery. The evidence is not clear, but suggests that men with larger varicoceles are more likely to have greater benefit. But even a grade 2 or a grade 1 clinical varicocele can be operated. The other way around, you have a couple who's already 5 years married, had tried medical therapy, it has not succeeded. Now their options are, should we go for IVF? And they come and you find a clinical varicocele. Then right away they have two options. They can undergo varicocele surgery, give it 6 months, or they could go in for IVF directly.
Okay, sir, after the varicocele surgery, the patient comes back to the gynecologist. So when do we repeat the semen analysis again? After 3 months? After 6
3
months?
months.
3 months.
Do one at 3 months and then one at 6 months.
I wanted to ask one question to Dr. Rupin, that after surgery, when the count comes back, would you suggest just a planned relation at the time of ovulation or an IUI? Is there any studies that have been done?
So it will depend on the semen quality. There have been studies showing that varicocele can downgrade the treatment required. So a patient whose semen was a candidate for IVF ICSI may now be a candidate for IUI. Or someone who could have been a candidate for IUI could now try naturally. So that decision, it's a good question. The decision will depend on the quality achieved. Somebody from 3 million who's come to 10 million, I would like to look at IUI, and particularly so if there's a concomitant female factor.
Rishikesh and Rupin sir, we have crossed more than 2,200 users right now, and they are enthralled by your answering, the way you have been going through the questions. There are many questions, but I am trying to take the most important of them. Thank you so much. It has been a wonderful time, but we are not going to leave you. We have still 10-15 minutes. Please be there. Rishi, I come back to you. Dr. Manjula is asking, can you elaborate on CRISPR? Unmute. Please unmute.
See, what is it? The bacteria, they kill the viruses. I hope we had Cas3-Cas9 with us presently, so we could have killed the COVID virus. But the Cas3-Cas9 is a protein system in the bacteria. That system has got a endonucleosis enzyme on it, and that system attaches to a RNA. So when first time the virus infects the bacteria, the bacteria creates a anti-RNA against the viral strand. And so when next time the virus infects the bacteria, what it does, the viral RNA is produced, the bacterial RNA, it attaches to the Cas3-Cas9 system, and that system goes and attaches to the viral RNA. As soon as the attachment takes place, there is a codon attachment. As soon as that takes place, the endonucleosis enzyme on the Cas3-Cas9 activates, and it cuts the viral RNA exactly 10 base pairs away. It's a exact mathematical cut is given. So now if we want to modify, let's say thalassemia gene we want to modify from an embryo. So what we will do is we'll take that embryo, we'll go to the gene library. So there the sequence of the thalassemia gene will be there. From that, we create a counter sequence and then we give it to the company. So company sends us the various nucleic acids in the form of a package. It comes by courier and you put all those nucleic acids into a PCR machine and create a counter strand to that gene which you want to cut. Then you attach that strand to this Cas3 Cas9 system and create a complex. Now this complex has to be injected into the cell to cut them, to inject into the embryo. That can be injected by micro manipulation, or you can inject it by electroporation. So you give a massive current to the cell. As soon as you give the current, the pores in the cell wall, they open up and these small complexes enter the cell and then they modify the DNA and cut it. You understood?
Yeah. Wonderfully explained. We have got questions from Argentina and Israel. Dr. Marijo Green, is it possible to achieve a pregnancy from a patient with sperm fragmentation more than 95%? Dr. Rupin Shah, this question is from Argentina, Dr. Marijo Green.
Such a case, we would take testicular sperm.
Okay. Thank you. Dr. Burzin Bahrain from Israel. What dose do you use for the leuprolide trigger in an IVF cycle? Dr. Rishikesh Bhai, this question is for you.
We are using the triptorelin trigger and we give 0.2 milligram. We normally 0.1 is enough, but I give double dose. And nowadays, because out of every 100 patients, we have 1 or 2 where the LH surge fails to occur. So I have created a new rule in my unit that the day, suppose tonight I give the trigger, next day morning LH level has to be done. If the LH by mistake is not there, LH surge is not there, we will create a rescue by giving a HCG injection and do the pickup after 24 hours. So this is because we had started getting some empty follicles after the GnRH trigger as compared to HCG, and we needed to create a system to see that we didn't have this kind of failure of oocytes we failure to get the oocyte. So this is a new add-on system which I've created.
Yeah. Continuing with the same question from Dr. Burzin Bahrain from Israel. What is the dose of HCG booster or HCG additional drug which you add? What is the dose?
Because we normally would give a trigger to prevent hyperstimulation. So we can't give a very huge trigger, but I give normally 1,500 units. But knowing fully well that once I give this rescue trigger, I'm going to land up with hyperstimulation. But it's better to land up with some kind of hyperstimulation as compared to no oocyte. So this is the new balance system which we have started doing.
Rishikesh, I'm not going to leave you. There is one more question from Spain, Dr. Pavel Travnik. Is anyone using the vaginal prometrium for the luteal phase support in fresh or frozen IVF cycles?
So we are using a lot of progesterone of every possible, because all the companies come to me and I've used everything. I think I can do a meta-analysis series over the last 10 years. I've used oral, I've used injectable, I've used vaginal pessary, I've used vaginal suppository, I've used vaginal gel. Everything gives the same outcome. There is no difference in the outcome. The pregnancy rates are nearly the same.
Okay. Dr. Rupin, I come back to you. What are the adverse effects of DNA fragmentation? What is the role of spermatic venography?
Okay, the two very different questions. If DNA fragmentation is increased, it will reduce the chances of natural pregnancy, reduce the possibility of IUI pregnancy, reduce IVF fertilization rate. It does not compromise the ICSI fertilization rate, but will impact early embryo development. So the embryo loss will be higher even after ICSI. So those are the clinical consequences of high DNA fragmentation. The second question was spermatic vein venography. That's a radiological process to diagnose a varicocele and also for treating a varicocele. So it results in a percutaneous embolization of the spermatic vein to block the varicocele.
Okay. Rishi.
Niranjan, I wanted to say that, I had always felt that, severely abnormal sperm may result in genetically high embryos. So one of the things you may do, we have now introduced pre-implantation genetic testing, but more than that, we have introduced non-invasive chromosomal screening. Without touching the embryo, we can do testing of the embryo. However, there has been studies which have shown that the outcome of genetic abnormality in patients with very severe counts as compared to not that severe abnormal counts is the same. I was under the impression that one of the indications may be highly abnormal sperm, one of the indications of pre-implantation genetic testing. But that's not so as far as the studies go. But if you have got repeated failures, as Dr. Rupin said, there may be in very high DNA fragmentation, maybe higher incidence of embryo loss or miscarriages. So we can screen these patients after the embryo is formed by using either an invasive or a non-invasive test.
Thank you. Dr.
And
Rupin,
one point in this COVID, because of this COVID infection, one of the fear is that if you breach the zona, there is a higher chance that if there is a suspected infection in the culture, the virus may enter the embryo. So in those, especially non-invasive testing will become a big boon, because in non-invasive testing, you don't open the zona and don't do a biopsy. You take the DNA which has leaked in the surrounding culture media.
thank you, Dr. Rishi. You have explained very nicely the procedure about going ahead and for conceiving the patients. Dr. Rupin, I'm coming back to you. There are two questions. What is the role of doing estrogen level in male partner? Second is, when do we do the male testosterone hormone testing when a patient comes to the OPD?
So if a sperm count is over 10 million, there's no need to do a hormone profile because it'll always be normal. When the sperm count is less than 10 million per ml, some people use 5 million per ml as a cutoff, then you need to do the hormone profile. And a basic hormone profile would be FSH, LH, and testosterone. If the patient is obese, then we also do estradiol. Now, typically in a male, testosterone expressed in nanogram per deciliter divided by estradiol expressed in picogram per ml should be more than 10. But in an obese person, because of excessive peripheral conversion of testosterone to estrogen, the testosterone drops and the estrogen goes up. And in those cases, when the TE ratio is less than 10, we treat such men with aromatase inhibitors, which will be either anastrozole 1 milligram per day on alternate days or letrozole 2.5 milligrams on alternate days.
There is a compliment from Dr. Murlidhar Pai from Manipal. He has said to both of you, including Dr. Jaideep Tank, very good lectures by the speaker. Thank you, Dr. Murli. We have got one more question from Dr. Harris Gabriel. I don't know, it's not mentioned here which country, but it seems to be Europe. Is there an association of polymorphism in gene coding for antioxidant enzymes and human male infertility?
Yeah, there may very well be polymorphism. In fact, we are finding more and more at multiple levels that individualization will matter. But as of yet, is it clinically relevant? No.
Okay. How long after varicocele surgery can we expect betterment in semen parameters? Dr. Rupin.
So usually we would wait for one spermatogenic cycle. That's about 65 to 80 days. However, therefore, I tell the patient to come back after 3 months with a semen report. But fairly often we'll have patients come in at 2 months also because they were inpatient, showing very good improvement. So the improvement can probably happen anytime after 1 or 2 months, but it's safer to check at 3 months because that's when you would expect to see improvement. Now, in the days when we were not doing microsurgical varicocelectomy, we had a greater chance of damaging the testicular artery. And in those days, we used to very often see a fall in sperm count during the initial 3 to 6 months. And the main improvement took place between 6 to 12 months, probably because of revascularization. When we are doing microsurgical varicocelectomy, preserving the testicular artery, improvement starts right away and may be seen at 2, 3, or 4 months.
Thank you. I think, Rishi, that question about main reason of degeneration after ICSI in human oocytes was asked by Dr. Purna Chandra Mahapatra. So it was so nice that PC sir has also joined. And there is only one person, PC is Purna Chandra. There is only one Foxian. So we are very thankful to him to ask this question. There are many questions. I would like to ask this to Dr. Rupin from Dr. Alka Varsne. Sir, CoQ, 100 milligram or 300 milligram for male infertility. What do you recommend the dosage?
There's no real evidence.
It's a general question.
Yeah, there's no real evidence that can tell you that, okay, 100 is better or 300 is better. So as an average rule, depending on the patient's body weight, we'll give 100 to 300 milligrams. But honestly, there's no clear-cut guideline. Companies will tell you for motility alone, give 300, for oligo, give 100. But there's no real honest answer to that.
Okay. Sir, I think we will have to close, but there are few questions more which are there. And this is from Italy, Dr. Brian. Can you see me? Yeah. Is there any improved fertility preservation care for male patients with cancer after establishment of formalized oncofertility? Dr. Brian from Italy.
Yeah, oncofertility.
Oncofertility.
As I told you that if the therapy has started, then of course there may be certain patients that may have a lower count, but we may still be able to freeze these sperms. But if the therapy has not started, and we can easily freeze the sperms. And if there are very low, because many of these people are very catches sick, so very low counts and all, we can use the new device that I told you about, the sperm ready device, to freeze the sperm. So I don't think
Dr. Rupin, your comment?
Oncofertility preservation is a whole field by itself. And I think the most important thing is for the oncologist to be aware that sperm should be frozen before the treatment starts. The problem is that these men, as Rishikesh said, are often very unwell and in a great hurry, and the window of opportunity for giving semen samples is very limited. But it's a real tragedy when we get men who've undergone extensive cancer therapy, now cured, now they're azoospermic, and they've not had a sample frozen. Then there are various other things. For example, with testicular cancer, one can even take out the normal testicular tissue from the orchiectomy sample, extract sperm from that, and freeze that. So there are many things, but it's a very important topic.
Yes. There are many questions being asked here, but I think we will have to close now. Both of you were wonderful. Dr. Jaideep also joined us. This was the first MOGS program which was done with Dr. Reshma Pai at the helm of affairs as the president of MOGS. And I would like to tell here that we did not only get questions from India, but we got from Latin America, from Europe, from Southeast Asia, and obviously from our own Indian doctors who have been keenly listening to your talks. They were so wonderful. There are still many questions which are coming, but we will have to close. I would just like to ask you one sentence each. We are already finishing the lockdown 3, and I'm sure there are many appointments waiting for you so that they meet you in person. Your patients are eagerly waiting. I would like to have one sentences from you. What is the status at your OPD situation, and how are you going to tackle this in the corona time? Because even if the lockdown moves off, it is still going to be corona time for a few more months. So just few comments on that, please.
It's going to be corona time for a long time. And I think we'll have to have a new style of consulting, of meeting, of interacting, of greeting, which minimizes contact, touch. Rishikesh, in fact, has been on a couple of webinars related to this. So he might have some more pearls to share.
So, first of all, I must say that it has been a fantastic, for me, it's a learning experience. Every time I listen to Rupin, even Jaideep Tang's lecture was very good. So, you always learn new thing, new concept. As far as the Corona time, as Dr. Rupin said, that there's a long time to go, nearly 1-2 years, I think we are looking at it. So, we minimizing contact, primarily creating 2 teams. As far as the sperm is concerned, because this is a sperm talk, so let me tell you that the viremia is not there in the corona positive. So if you have a corona positive patient, you are anyway not going to touch it as much as possible, unless it's for cancer. She's for cancer therapy, and you have to do it. But otherwise, our policy is going to be that we are going to test the patient by PCR before we take them for the procedure. And if there is a positive, we will not touch it. If the husband is also positive, we are going to test the husband also before he gives the sample, for 3 to 4 days before he gives the sample. If he is positive and wife is negative, we may do the pickup, freeze the oocytes, and then wait for the husband to become negative again, and then maybe thaw the oocyte. So this is the first priority. Again, you need to have 2 teams. So like what we have done is, we have our first team of 5 people are going to run the whole. Everyone else is going to be at home. They will run the OPD. They are going to start the first batch in the first 10 days of June. Our first frozen thaw transfers, pickups will happen at that point in time. We are going to do, if I get the access, both the tests, that is PCR and the antibody test will be done. If I don't have, and of course the triage will be done. And based on that, triage will be done for all the 4 people, the healthcare workers, the anesthetists, the embryologists, and the ultrasonologists. They are dangerous people, ultrasonologists and anesthetists, because they may spread the disease. So all of them will be tested. And by using that method, using proper PPE, you will be able to, I feel, run your life. Plus, what I'm doing is I'm also putting a high intensity ultraviolet light in my air handling unit duct, which doesn't break the oxygen into ozone. And we are also putting a photocatalytic titanium converter, which will kill the virus in our ducts. So these are some, but this is not necessary. This is my add-on, which I am doing it for my own happiness.
I think to summarize, I would like to tell that all the 3 of the lectures were superb. They covered major aspects of infertility, especially to begin with Dr. Rupin Shah on the male infertility, the sperm issues, and the way you have explained the modes of surgery, when to do, how to do about, what is the interpretation of the ultrasound report, when to start the medical line of treatment, and when to go ahead with the surgical line of treatment. There are many data globally all over which have proved and have said that CoQ 100, when given for about 3 months time, it surely improves the sperm parameters, and that's what the literature says. Dr. Jaideep Tang has also very well told us about the diminished ovarian reserve and what are the methods to improve. And also he talked and touched upon endometriosis, cystectomy, fulguration, and the drugs which are used for diminished ovarian reserve. Dr. Rishikesh Pai, you took us 100 years beyond 2020, and you also told what are the latest things which are happening and the role of ICSI which has been done, and you are the pioneer which you started in 1996, and now we are talking about CRISPR, and you also went through the studies of Japanese technology and the European technology. We had more number of people, to be precise 2,218 users which logged in, and we have gone beyond 2 hours to hear all you speakers and the question answer session which went so wonderfully. You have been very nice, you have been so good, you have been also fast to give us and a precise information to the point. So doctors have logged in and they are enjoying your talk. I would like to close this talk and the session by displaying an image. Let's have the image here in front of us, and this tells you an image from Spain, and you can find that a day will come when we are traveling together. This will be small cubicles small electronic cars, and this has been predicted in Spain about 50 years back that in 2022 we will be like this. But I hope that this ends soon, and if the vaccine comes, it was too good. To be precise and correct, this was spoken way back in 1951, and in 1951 it was said that in 2022 we would be moving on the streets like this. I hope this situation doesn't come. Thank you, all of you. Wonderful. You have done a wonderful job. Thank you so much.